Welcome to this lecture, in which we will be talking about complication of diabetes, both acute and chronic. Part one, I will be talking about the acute complication, namely hypoglycemia, diabetic ketoacidosis, HHS, hyperosmolar syndrome, also previously known as the HONC. First, I'll start by talking about hypoglycemia. Before that, so what is hypoglycemia? Clinically, hypoglycemia is a blood sugar below 70. I have to mention also that the brain relies exclusively on glucose as fuel. Thus, physiological and behavioral mechanisms have evolved to rapidly correct hypoglycemia whenever it happens. The way our body counteracts an onset of hypoglycemia is by the by the activation of the counter-regulatory hormone, which I talked about in diabetes lecture, namely glucagon, growth hormone, cortisol, and sympathetic nervous system that is mediated via epinephrine. Hence, the symptoms that we will be seeing are basically mediated via two pathways. There is the autonomic manifestation of hypoglycemia that is manifested as shaking, tachycardia, painless, sweating. This is directly the result of the activation of the sympathetic nervous system when the epinephrine is released, and also we see some manifestation that also due to the activation of the parasympathetic nervous system. Neuroglycopenic manifestations. These are, you'll see the symptoms because they are mediated via the effect of hypoglycemia, the direct effect of hypoglycemia on the brain. So you will say slow thinking, slurred speech, slurred vision, dizziness, irrational behavior, seizures, and if the blood sugar is really low, you're going to see coma. I just would like to mention some numbers. Glucagon usually kicks in when the blood sugar is between 65 and 75, and then epinephrine will kick in if the blood sugar is between 65 and 75. This is the pathway through which we're going to explain these symptoms. When the blood sugar is decreased, the peripheral sensors send a message to the brain, to the central nervous system, and the central nervous system reacts by sending messages to the pancreas, more specifically to the beta cell. The blood sugar is low, we need to decrease insulin. But in type 1 diabetes, there is no insulin, so basically this is the effect of exogenous insulin administration. Also, the brain or the central nervous system will activate alpha cells to release more glucagon. Glucagon would activate the pathway of glycogenolysis and gluconeogenesis, which result in increase of blood sugar. Also, the sympathetic nervous system is going to be activated through to the release of epinephrine, adrenaline from the adrenal medulla. Epinephrine has the similar effect as glucagon. It activates gluconeogenesis and glycogenolysis. It will also work on the periphery to block the uptake of glucose from the periphery. It will also order, if you would, the kidneys to decrease the clearance of glucose. And then the epinephrine, as I said previously, will result in palpitation, tremor, and arousal. The parasympathetic nervous system that is activated via the acetylcholine will result in triggering the hunger so that the patient can digest more glucose. Treatment of hypoglycemia, if the patient is conscious, can take PO. We give them 15 grams of simple carb in the form of 2 packs of sugar, 5 to 6 hard candies, apple juice, orange juice, milk, soft drinks, you name it. If the problem is still there is a problem, you repeat every 10 to 15 minutes. Of course, you're going to be with the patient, checking sugars every 10 to 15 minutes. And once improved, you can give them bread or 8 ounces of milk to prevent recurrence. However, if the patient is unconscious with no IV access, give glucagon IM. You're still going to be checking the blood sugar every 10 to 15 minutes, and if IV access is available or is established, give D50. I would like to talk a little bit about hypoglycemic unawareness. It's not an acute complication, but it is rather somewhat chronic, if that's a word is in the English language. So hypoglycemic unawareness is found in patients with long-standing type 1 diabetes. It is dangerous because these patients or these clients no longer have the warning symptoms of impending hypoglycemia that prompt them to take appropriate preventive action. This syndrome, if you would, or is reported in almost 50% of all clients with long-standing diabetes. How can we explain what happens in hypoglycemic control? And before I say that, it is dangerous, because imagine if somebody is operating machinery, driving a car, driving a boat. There were actually cases of reported drownings because of hypoglycemic unawareness. How can we explain hypoglycemic unawareness? So I have to say that at the beginning of diabetes, of the onset of diabetes, the glucagon response to hypoglycemia is almost normal. However, as the disease progresses, patients with diabetes start losing this response mechanism, and they start relying almost exclusively on epinephrine. Start relying exclusively on epinephrine to protect them against hypoglycemia. However, epinephrine response to hypoglycemia becomes attenuated, becomes dull, because of especially in the setting of antecedent hypoglycemia or recurrent hypoglycemia. And the way the sympathetic nervous system start reacting and becomes attenuated is because in the setting of recurrent hypoglycemia, the body actually lowers the threshold for hypoglycemia when you're going to start initiating a response. And with repeat, as the blood sugar keeps getting lower and lower and lower, the threshold for response via epinephrine gets lower and lower, resulting ultimately in hypoglycemic unawareness. I would like to talk to you briefly about one of the dermatological complication of diabetes. This is chronic. It's called acanthosis nigricans. Acanthosis nigricans literally means thick black skin. You will see it. It is associated with hyperinsulinemia or long-standing hyperglycemia, typically type 2 diabetes. And you see this manifestation under the armpits, in the groins, under the breasts, and in the neck. So if I see somebody with this, I usually advise them to have their sugar checks for diabetes. And to end, I'm just going to share these pictures with you about diabetes ulcers. I'm not going to mention anything about it. And I will see you.